Thank you for that welcome. I'm really pleased to have this opportunity to talk to you about the economics of psychedelic-assisted therapies. So in the next few minutes, I want to consider these questions. So what I want to cover in the next little while are the following points. I want to address the question, why economic analyses? Why are they important? Why should we care about them in the context of psychedelic-assisted therapies? I want to present to you some kind of iconic major types of economic analyses and discuss the purpose of each. Then I want to give you an example of a relevant economic analysis that we're working on pertaining to the sensitivity of payers' perspective on cost as influenced by the cost of MDMA itself. So I'm not talking about the whole MDMA-assisted therapy. I'm talking about the cost of the drug itself. So I'll run through that example. And then I want to talk more generally about the agenda for the economic analysis program going forward and the values that I believe should be intrinsic to it if it's going to make the contribution that it could make. Let's see, I need the next 2 slides. Do I need to point this at something? Keeps going back. Okay, so why economic analyses? As you know, there are selected, currently Schedule I drugs that may soon be part of legal therapies. As is appropriate, the work on safety and efficacy has vastly superseded the work on economics. Makes total sense. Why would you spend time on an economic analysis of a therapy that doesn't have proven effectiveness? So we're now in an era where we have substantial indications of effectiveness for a range of emerging therapies. And so the question is, what is the value for money of these therapies? Effectiveness is not the same as economic value. And the question that we're concerned with is, are these new therapies better than the current therapies in some meaningful way? And is the extra benefit worth the extra cost? Which is another way of asking, are they cost effective? These analyses are critical for the mission of the gatekeepers to large-scale access to these therapies, and I'm referring to healthcare payers, private investors, policy actors of various kinds, advocates, and educators. And all 4 of these stakeholders need rigorous, objective economic appraisal if they're going to support psychedelic therapies and if payers are going to make psychedelic therapies a benefit for their members. So the goal, simply, is access to psychedelic therapies for all those who can benefit. The emphasis up to this point, correctly, has been on safety and efficacy. More recently, emphasis has gone toward understanding what care delivery models will work, will be equitable, and will provide maximum access. And I'm now suggesting that we're in an era where rigorous, transparent economic analysis is as important as these other 2 pillars if meaningful public health scale access is going to develop out of these efforts. So let me talk about types of economic analyses. I'll go through, there's a lot of words on this slide. I'll go through them quickly. The fundamental type of analysis is cost analysis. What does it cost to deliver these therapies? And then, what is the net cost? So what's the cost of delivering the therapy adjusted for downstream changes in healthcare costs? Usually we suggest that those costs would decrease as symptoms diminish, as people benefit from therapies. The second is cost effectiveness analysis, which really, as I mentioned earlier, it's a way of talking about value for money. Is the extra cost of this therapy over standard care, at least the extra upfront cost, can that be justified by the extra benefit? Cost-benefit analysis is another flavor of value for money analysis. Then you were also interested in what happens if you scale up access to these therapies? What if 10%, 20%, 50% of people who could benefit had access? How many lives would be saved? How many quality-adjusted life years saved? And what would the net savings to the healthcare system be at scale? So we're working on models to describe that. Price analysis. What's the appropriate price for these therapies where we want to weigh increased access might argue for lower price, but on the other hand, if you have a public benefit model, the excess revenue could be recirculated into support for advocacy and research. This is MAPS's basic model. And so how do you balance those two objectives and arrive at a balanced, reasonable price for psychedelic therapies and for the drugs themselves? And then finally, we're really interested in methods development. So we health economists are stuck in the last century. We think that health status goes from 0, which is you're dead, to 1.0, which is you have no diagnosable condition. We don't recognize, and we have no way of systematically quantifying the positive cognitive and emotional states that people repeatedly report after exposure to psychedelics, both in clinical and non-clinical settings. And so we're working with Dr. Keltner and Eduardo Schoenberg and others on methods by which we can import these broader understandings of the well-being benefits of psychedelics into economic evaluation, because I believe our current primitive method underestimates the benefits of psychedelics. It would also be a service to the field. I mean, these positive health states aren't limited to exposure to psychedelics, but arise elsewhere as well. So here's an example of the kind of analysis that I think is important to inform payers so that they can proceed with confidence and due diligence in considering adoption of these therapies as benefits for their clients. So the first is net cost. What does it cost to deliver this therapy, adjusted, as I mentioned earlier, for savings down the road in healthcare costs? So cost. Cost effectiveness. Now we're bringing in healthcare benefits. And again, it's the value question. Can the extra cost be justified by the extra benefits, compared with other uses of the same money, or compared with standard of care? Another metric, which is particularly important, is break-even time. So psychedelic therapies are relatively expensive up front, and the savings accrue over time. So the question is, how much time needs to elapse before the payer roughly breaks even? And after that, they're getting sort of excess revenue. So this is a metric that payers are definitely concerned about. And then finally, percent of operating revenue. Something could be effective and cost-effective and simply be very hard to accommodate in the existing budget of a given provider. Okay, so this graph portrays the net cost or savings of MDMA-assisted therapy at various levels of potential possible costs of the MDMA itself. I want to emphasize the cost of the MDMA has not been set. It may be considerably higher than the high end of $20 per milligram that I'm using in this example, and it doesn't really matter for the point I want to make. And you'll see what I mean in a minute. So on the left hand of the graph, you see the net cost of MDMA therapy. So again, net cost is the cost of a therapy adjusted by savings over time. If you're only looking at 1 year, you don't get much savings, and so the left half shows net costs. They're actually out money at 1 year. If you take the horizon, the analytic horizon out to 3 years, the net costs go down. This is totally realistic. We have at least some preliminary data that suggests that MDMA AT therapy provides benefits, and in fact enhanced benefits, for at least 3.8 years. And I know MAPS is looking at a longer term output, so we may get some more interesting data on that soon. But after about 5 years, you start to see savings. So the graphs below the line are good. That means savings. And the lower the cost of the drug, the greater the savings. But you can see that the drug costs actually don't drive the degree of savings nearly as much as the analytic horizon. So, can I have next slide? I think I need support from up there. Okay. So I'm just assigning some numbers so you get a sense of it. So at a 1 year horizon, which would be pessimistic, basically we're saying all benefits stop after 12 months following therapy. The cost would be $18.6 million if the drug cost were $20 per milligram, and 11.5 if the drug costs were $1 per milligram. And on the other extreme, we'd have savings of about $45 million, $46 million if drug costs are low, and a slightly lower amount of savings if the drug costs were high, about $39.5 million. The point is that drug costs, that the net savings are actually quite insensitive to the cost of the MDMA therapy itself. And I want to emphasize that these are illustrative numbers to get a sense of what the sensitivity of net costs is to the price of the drug. We don't know what the price of the drug is. It's going to depend on FDA labeling and market conditions, and could be considerably higher than $20 per milligram. So don't get any particular number in your mind like that's the cost of MDMA. We don't know yet. So now the question is the intervention cost effective over the full range of MDMA prices and analytic horizons? And if you look at the cost ranging from $1 to $20 per milligram, you can see that, again, at 1 year cutoff, the cost per quality, that's bad. High numbers are bad. That's not cost effective. The more money you have to pay for a quality, the worse. But if you look at 3 years, it becomes much more cost effective. And if you think about, well, so at even at 20 years, the cost at 1 year of therapy would be about $70,000 per quality gained. Is that good or bad? Like, what's cost effective? What do we mean by cost effective? So in the United States, somewhere between $100 and $150 per quality gained is pretty good, especially on the $100,000 side, but even $150,000. So even at the negative scenarios offered here at $70,000 per quality is pretty good, not bad. And I only show results for the 1 year and 3 year horizon because anything after 3 years, it's not cost effective, it's cost saving. You don't compute a cost effectiveness ratio. So it's the kind of gravy after that. So it's very, very favorable if you take slightly longer time horizons. Now let's look at another metric, which is the break-even time for the price of MDMA. What this slide illustrates is that the break-even time is also insensitive to the cost of the MDMA. So at $1, it's 3.7 years. If you multiply that by 20-fold, it just goes to 4.7 years. So again, a higher drug cost does not radically affect break-even time. So an important caveat, these favorable results depend on an analysis of the kinds of patients that were seen in the MAPS phase 2 and particularly the phase 3 trials. These were people with extreme or severe PTSD, they were treatment resistant, and they had chronic MDMA from between 14 and 18 years since diagnosis. If there's an effort to include less severely affected people, cost effectiveness will reduce and perhaps dramatically for a variety of reasons. In the interest of time, I'm going to move on. One more metric I want to introduce to you that will be of concern to payers is what % of their gross revenue would be needed to finance this kind of therapy. So I use the example of Kaiser Permanente, which has an annual operating revenue of about $93 billion and would treat about 170 million people who would be eligible for treatment. At $5 per milligram for the MDMA itself, the cost of the MDMA therapy would be something like $13,000. The cost over 5 years would be about $439 million for Kaiser alone. And if you look at the $20 per milligram scenario, of course it becomes more, where the cost over 5 years would be about $630 million. Is that a lot? Well, one benchmark is that for a large public payer, $100 million would be considered cost prohibitive. They'd have to find some way to spread those costs over more time. And for a public payer, about $50 million. So that could be an issue. So our group at Berkeley is working on a number of economic analyses. We're working with Johns Hopkins on psilocybin therapy for smoking cessation, cost effectiveness of psilocybin for relief of major depression in conjunction with USONA, MDMA for PTSD in Brazil. We are a global initiative and want to be working in as many developing countries as we can. We're also looking at the effect of psychedelics in non-clinical settings. There's a major literature review project. We have a proposal into the Department of Defense that's under evaluation on the economics of MDMA for active duty military, and we're also developing an opioid use model for Ibogaine. Guiding principles, scientific rigor. We follow the data. We publish what we believe is accurate. And so we're looking for sources of support that will allow us that academic freedom. We believe in teaching and mentoring. We're developing an increasingly large network of academics and students who want to work with us. We're forward-looking. We're trying to see the next likely therapies that will be effective and therefore should have economic analyses done to them. We're concerned with equity and the possible trade-off between equity and efficiency and understanding that and measuring it. And we are, as I mentioned, global in scope. 85% of people with major mental health problems are in low and middle income countries. We need to find a way to accelerate access to the 85% of the population of the planet that really needs it. So the broader agenda for economic evaluation of psychedelic therapies, I developed a little formula, and it goes like this. It's the molecules and combination of molecules multiplied by the number of relevant psychiatric indications, multiplied by the number of patient subgroups, multiplied by variations in treatment regimens, multiplied by the number of countries that any of this could be applied to. And I did the math, I worked out the numbers, and the answer is there's a lot of work to do. So I'm looking for partners and delighted to be engaged in this enterprise with you all. Thank you.
Next, we'll hear more about the payer perspective from Wendy Waring. Wendy Waring is the president and CEO of the Network for Excellence in Health Innovation. NEHI is a national nonprofit member-driven organization focused on advancing innovative care models and technologies that address unmet needs and improve equitable access to health. Prior to NEHI, Waring had leadership positions in both the nonprofit hospital and public sectors, spanning operations, strategy, partnerships, and regulation, with a special emphasis on equity and accessibility for underserved populations and children. Let's welcome Wendy.
I'm going to stay at the podium hoping that my notes will help me advance the slides, but we'll see. Do they? It says no signal. Well, I think you jinxed it. Is it? Maybe it's the other way around. Ah, I got it. It's important not to hold it upside down. Okay, so you've heard a little bit about knee-high. I'm just going to tell you, we call it knee-high, what I'm going to talk about today. It's a little bit about the payer perspective, so that part of the introduction was accurate, but mainly I'm going to talk about the importance of considering access from a system perspective. So this has been such a rich discussion so far, but you can see that whoever is speaking speaks from their perspective, and I'm going to talk about the importance of defining dialogues that get people to talk together about given problems rather than approaching it from their own perspective. You know, Regina Hertzlinger at the Harvard Business School, I'm from Boston, has made an incredible career about why innovation is so hard in healthcare. As you heard today, healthcare is an incredibly complicated system. And the part that I'm going to argue is that if you approach it from the stakeholders, and in this case from the stakeholders of psychedelic therapy, including patients, payers, clinicians, providers who are different from actual clinicians, you will use and approach each of these issues. Oops, sorry. So I'm going to start with patients. Patients have a number of access issues, and when I say patients, I am talking from sort of a medical model. The first that hasn't been mentioned quite as much, although one person did mention it, is the adequacy of screening and diagnosis. So identifying in settings where patients go, the right patients to receive the right therapies is incredibly important. And most of you probably here know that screening for mental health and behavioral health disorders in primary care is suboptimal. So we estimate how many patients can benefit from psychedelic therapies, from other mental health therapies, but people aren't trained and don't have the tools with which to screen and diagnose, which is an important aspect of developing an evidence-based treatment plan. Cost is going to be another barrier. So insurance coverage or payer, the decision by payers to cover psychedelic therapies certainly will be influenced by FDA approval. But FDA approval does not guarantee coverage. Payers are still going to be able to make decisions. For Medicaid and Medicare, FDA approval is going to be absolutely critical, but payers do have the ability to apply prior authorization. And in the case of psychedelic therapies, they will be well supported in applying prior authorization on the argument of efficacy, safety, appropriate setting, appropriate clinician. And I'll talk more about that in a minute. Availability. So it's not just about are there enough clinicians, and we all know that the shortage of psychiatrists is a huge issue. But are there settings where you can combine the administration of drugs with the therapeutic intervention? Fourth, convenience. So patients now may favor, clearly favor, can I take a pill, will I get better? These therapies, as many people have said, are longitudinal commitments. They require both therapy and fidelity to taking certain drugs. And so for many patients, I would be among them, the convenience and time required to engage in these therapies is going to be significant. And that's going to be a major issue in equity. For those who are on Medicaid, taking time away from work, finding the ability to access these therapies is going to be significant. And last on my slide at least, and I'm sure it's not last, you've all thought of more of these barriers, but is the transition from other medications. So I did run Medicaid in Massachusetts for a couple of years. The average Medicaid patient who was being treated for behavioral health was on 5 SSRIs because they could not transition from one SSRI to another. And I really better get moving here. So the other thing is, as we look around the room, innovations should be about improving health equity and making health better for everyone. Disparities in attitudes and acceptance of psychedelic therapies are going to be a fairly significant issue. You can see some of the headlines, and much is written about that. Sorry. Uh-oh. Very sensitive clicker. So from clinicians, I'm not going to spend a lot of time on this slide. From clinicians and providers' perspective, training and certification, licensing issues will be significant, and that will depend on the availability and acceptance of evidence-based guidelines. The biggest issue I will submit for clinicians will be reimbursement. So it's not just what is paid for the drug or what is paid for the therapy, but whether payers insist on value-based arrangements and the quality and metrics they will use to continue to monitor the effectiveness of the therapy. Workflow and space requirements will be significant, as will clinicians' own stigma and attitudes. And the one thing I skipped over a little bit that we don't talk about so much is payer mix. So if a clinician decides to bring this therapy to their patients, will they attract public payers, publicly insured payers, which will adversely affect their sustainability and payer mix? You heard a lot about payers. What I want to emphasize here is that payers have multiple coverage decisions to make. They will be affected by the laws, regulations, and politics. I do not have enough time to go into the Mental Health Parity and Addiction Equity Act. That will have a huge influence on how payers treat these therapeutics. But they will develop prior authorization, and that will restrict access both for the right reasons and for the wrong reasons in terms of who has access to these therapies. And last, they have to decide, as Dr. Marseille said, on what they're going to pay and how they're going to pay for these drugs and therapies. So, knee-high, what do we do? What's our value in this ecosystem? Our notion is that you must define clearly the problem that you're trying to approach. And before you do that, trying to attack each of these issues separately will not advance the solution. So from a developer point of view, I'll just take a developer point of view. We have a lot of investors here. Who are the patients that you have to reach in order to maintain, to provide, to fulfill your mission and to be financially sustainable? Who provides their care? Where do they get their care? Who pays for their care? Who are the patients most in need of access to the therapies? We are a very white audience here. If we want these therapies to reach and improve health equity, we are going to have to approach this from a Medicaid perspective. We're going to have to look at public payers and really get them on board with the idea that these therapies work and are providing benefit. And then deciding financial sustainability will be critical. So our pitch is getting the right patients, payers, and providers to work together, define the problem, and then proceed with a stepwise approach. Usually we start with the patients or the providers so that we can get their understanding of what the issue is, and they will go through each of these issues. Since I have 13 seconds left, these things take time. Josh referred to the notion that the nuts and bolts issues were going to be important in 10 years. My pitch is that they are important today, even as we are, building the evidence, communicating the evidence. We have to start from a multi-sector perspective, tackling each of these issues now, forming the relationships to do so, really forming collaborations, building advocacy groups, and then piloting solutions that those groups come up with. Thank you very much.
Thank you for laying out some of these questions for us. I want to start the Q&A with Elliot. I have a question about the break-even timelines, right? It looks like this would be a no-brainer in a single payer system, but the reality in the US is that the payer system is very fragmented, right? How do we think about the timelines that payers look at, right? Because people are switching employers, and how do those timelines align with what we see and anticipate with psychedelic therapy?
Yeah. So a couple of things. One is those break-even times are in the context of highly resourced clinical trials. When we get into the real world, it's not just in psychedelic. We see this, again and again in public health. It's the difference between efficacy, which is the benefit observed in a clinical trial, and the effectiveness out in the real world. So there's good reason to think that effectiveness will fall, that some of the stringent exclusion criteria used in the trials may be relaxed, and with the consequence of worse results, let's just say, less benefit. The other thing is, there's this nasty word called churn in the health insurance industry, I think in any industry. And here's the thing. The data show that approximately 20% of patients per year migrate from the plan that they're in to another plan. So what that means is that the health insurer that pays for the relatively expensive upfront cost of a psychedelic therapy is not going to get to recoup it because 20%, or won't recoup all of it, because 20% of the people who got the therapy now leave, and they're taking their better mental health to another carrier that gets the benefit. So they're looking at this and saying, in theory, break-even might be 3 or 4 or 5 years if people stayed in the program, but they don't. And so this churn factor is another dimension that insurance companies are going to be looking at. So in a way, those break-even points I mentioned are too optimistic. They assume no churn. On the other hand, there's a study that came out in February of this year by Hanming Feng, who said, yeah, churn is about 20% per year, people leaving, but nobody had studied how many come back. And a substantial number come back, so that churn rate of 20%, maybe effectively it's more like 15, but it's still a lot. It's still like let's just say roughly 15% per year net churn. So the payback time may be a very important consideration that companies will want to look at, and it'll vary from company to company and market to market. Areas where there's a lot of price control by a few large insurance companies, they can expect to hold on to and retain more patients. So it's highly variable. And then I've talked to people in the insurance business who say, we don't care about cost effectiveness. You can take it however you want, but they're saying, if something's effective, we'll find a way to pay for it for our members, even if it doesn't save us money. And of course, insurance companies and health plans provide all kinds of health care that doesn't save them money, but is good value for the health. So it's complicated. I hate to say it, but it is complicated, and it will depend on the insurers and how they perceive the risk of introducing a novel therapy that still has some residual stigma.
You had also mentioned, I'm just going to be 2 seconds, something that's very important, that improvement. You don't have to go from 0 to 1, so improvement in mental health status. Insurers will see that as a benefit because of the comorbidity effects that behavioral health has on physical illness. So showing that as a benefit is going to be very important, and fortunately, because of all the attention on behavioral and mental health needs, any incremental solution that improves behavioral and mental health is what payers are looking for.
I think that's a really important point. And I really want to focus on analyses that look at savings in all healthcare costs, not just psychiatric healthcare costs, because I'm guessing almost everybody in this room knows that mental illnesses are implicated in various kinds of diabetes, cancer, cardiovascular disease, various diseases that have inflammatory responses. And in fact, a lot of the expected savings in healthcare are not on the psychiatric side, they're on the physical medical side. So I don't like to look at studies of healthcare savings for reductions in mental health problems that only focus on the psychiatric. It's not a sufficiently broad look at the benefits.
And on that note, can we maybe talk a little bit about how these treatments compare to the cost for typical surgical interventions? And maybe, Wendy, that's a good chance to talk a little bit about mental health parity.
So I actually winced at that when somebody mentioned it this morning. I think we are trying to look at parity between physical and behavioral health. And so in that sense, that analogy was right, that you're going to look at whether this has the same treatment effect as a surgical treatment effect. But pricing is going to depend increasingly on the value to the patient. And how that is determined, I think, as Dr. Marseille said, will be looked at on a cost-effectiveness basis. The problem for clinicians is defining their cost. So surgeons are able to define what their cost is. They look at their salary, they look at the OR time, they look at the equipment that they need. For clinicians, determining their cost, and you can, even in large academic medical centers, is incredibly difficult. And so you're still going to be held to what is the cost of the drug. The Inflation Reduction Act is going to come into play here, and what is the benefit to the patient.
And we've spoken plenty about the cost of the drug. How do these considerations change as we incorporate the cost of the therapy?
Say again, how?
We've been looking, in your analytics, we've been looking at the cost of the drug
Right.
and break-even times, et cetera, for that. How does that calculation change as we incorporate the cost of the therapy?
Yeah. So first, just a simple arithmetic truth. The lower the cost of the drug, the smaller, the greater is therapy as a total of the portion. When we're getting up to around $20 a milligram, it kind of gets to be 50-50 cost of therapy and cost of drug. I want to introduce another caveat here. When I say the cost of therapy, I made a very simple-minded calculation for want of better data, which was basically an 8-hour psychedelic session. I was assuming that the therapist would get reimbursed at 8 times a 1-hour session, just because, and I checked it out with, healthcare finance people. I say, yeah, well, of course we don't know. There is no CPT code for an 8-hour session, but that may be sensible. And I heard a comment earlier today that, maybe you need to provide a premium for those 8-hour sessions if you're going to incentivize people to do those sessions. So I don't know, sort of a long way of answering your question. But obviously, all else equal, the greater the drug cost, the smaller the therapy cost is as a portion of the total.
Hard question.
Wendy, maybe you can give us a little bit the lay of the land of what the main barriers will be to get public and commercial payers on board with this.
I think demonstrating efficacy will be one, but one of the things we considered looking at this, at the very issue, is to look at which states are promoting innovative therapies. Oregon would be one, Massachusetts, California, and actually going forth and talking to them about their concerns. I think they will look at the scope of patients they have. Medicaid does cover, over 25% of non-elderly folks with behavioral health and mental health disorders. But there will be no substitute from talking to the more innovative Medicaid programs in the country and really exploring with them what they will require. I think many of us could guess. Alabama is going to take a very, very different approach, no offense to those of you who are from the South, than Massachusetts or than California. And starting with those programs that are most likely to adopt these therapies because they're so concerned with behavioral health is, I think, the way to go.
Thank you so much. I think there's so many more questions, but we're out of time, unfortunately. So thanks again to our speakers.